Good day, everyone. Welcome to the Ophthalmology Times webinar, Antibiotic Resistance Among Ocular Pathogens, the ARMOR Study 5-Year Surveillance Results, featuring Dr. Penny Asbell. This is Mark Lugos, Group Content Director of Ophthalmology Times and moderator for today's program. I want to thank you for joining us. To formally start the program, I'd like to introduce our speaker, Dr. Penny Asbell. Dr. Asbell is Professor of Ophthalmology at the Icahn School of Medicine and Director of the Cornea Service and Fellowship at Mount Sinai Hospital in New York City. Dr. Asbell graduated from the University of Chicago with a bachelor's degree in biochemistry and received her medical degree from the State University of New York at Buffalo. She did her internship in internal medicine from Yale University and followed that with an ophthalmology residency and a fellowship in uveitis and in immunology at New York University. Dr. Asbell later did a corneal fellowship with Dr. Herb Kaufman at the Louisiana State University. She also received her MBA from Baruch College of New York. Dr. Asbell is a dedicated researcher and an accomplished clinician and has vast leadership experience in many professional organizations. Her clinical and research interests include dry eye, biomarkers of inflammation of the ocular surface, exploratory imaging of the ocular surface, corneal cross-linking, and antibiotic resistance. Dr. Asbell has received many honors during her career, including the American Academy of Ophthalmology's Life Achievement Honor Award, a Fellow of ARVO, the Women in Ophthalmology Suzanne Veronneau-Troutman Award, and the RPB Physician Scientist Award. It is a great pleasure to turn the program over to Dr. Penny Asbell.
Thanks, Mark. It's a real pleasure to participate in Ophthalmology Times webinar series. And we're talking about antibiotics today. Now, we all know in ophthalmology that eye infections are a serious business, and we want to pick the best antibiotic we can to prevent infection or to treat it once we make that diagnosis. So the question today, and what we're going to cover in the webinar, is where do surveillance studies come into our understanding of how to pick an antibiotic and how to pick the best one. Today I'm going to be talking, as I said, about the surveillance studies that I've participated in. I actually don't have any financial interest related to them. You can see in this slide at the bottom I mentioned a recent article that I was co-authored in JAMA, specifically addressing the ARMOR study in the last 5 years of data. The question comes up, why do we do surveillance studies? You know, for many years now we've seen in our journals studies of ocular isolates and whether or not the isolates were resistant or sensitive, etc. And some of them come from very well-known ophthalmology centers. But typically, as shown in this slide, they're small studies of typically a very small number of isolates. And that's one of the issues that we see. When you look at the studies that were published up into the surveillance studies that I'm going to review with you today, they're typically from a single center, retrospective. They're not really going over prevalence. They're a single infection source, such as keratitis or endophthalmitis. And most importantly, they're a small sample size. And they may even have a very limited antibiotic protocol that they're looking at. When you look at this slide, this gives you some idea of what's important when you look at data. So if I report on a small number of isolates from my center, which are 10, that may be a big number of isolates, let's say for corneal ulcers or endophthalmitis. But when you look at it statistically, that is not a big sample. So when you look at the graph in this slide, you can see if I'm only reporting on, let's say, 10 isolates, which is the red bar at the top, my confidence in that information, maybe 1 out of 10 were resistant, is really all over the place. Maybe that means almost nothing at all, 0 resistance, or maybe it means almost as high as 45% resistance. As I look at the confidence interval, it changes with the number of isolates I'm looking at. So if we get to the bottom bar graph in red, and there we're looking at 100 isolates, and 10 of them are resistant, it's still the same percentage, but our confidence interval, the red interval, is much smaller. So it turns out that if we were presenting at an infectious disease conference, we'd have to report at least 30 isolates for anybody to think the information is valid. And that's going to be pretty hard to obtain from a single center, even if it does see a lot of patients and collects a lot of data. What you can see in this next slide is that when you look at a surveillance information, you can begin to see trends. That's something you're not going to see from a single center. And even if by chance they do have a lot of isolates, it may not be very indicative of what's going on in a bigger geographic area. So a surveillance study, besides getting us the right numbers to be statistically valid, meaning over 30 per isolate, it also can look at trends that are happening over time in a much more valid approach. And this is a slide out of a paper I presented some years ago, looking at Staph aureus over the first part of the 2000 decade. And what you can see is that the methicillin-sensitive staph numbers went down, while the methicillin-resistant number of staph went up. And that's why I got involved with Ocular TRUST. Ocular TRUST tracks for ocular tracking resistance in the United States today. And this was a nationwide surveillance study of antimicrobial susceptibility against common ocular pathogens. It was done over a number of years. It's a longitudinal pattern from 2006 to 2008 and indicated that antibiotic resistance levels continued to be very high over that entire period of examination. The ARMOR study took up the helm of a continued United States-wide surveillance study of specifically ocular isolates. I might mention at this point that surveillance studies are commonly done for other infections such as pneumonia, blood infections, etc. What we've started in the last decade is doing surveillance on ocular isolates. And ARMOR, which is named for Antibiotic Resistance Monitoring in Ocular Microorganisms, was begun by Bausch & Lomb funding in 2009. And at the current time, it's really the only nationwide antibiotic resistance surveillance program specifically focused on common ocular pathogens. The purpose of ARMOR is to report resistance rates among isolates collected over 5 years in the ARMOR study. And this is what we recently published in 2015 in JAMA Ophthalmology, and I'm going to share some of the key findings of that study with you and hope that you'll find it useful for picking an antibiotic for your patient care. Well, how is ARMOR done? Basically, we look at participating sites throughout the United States. This could be an eye center that sees an awful lot of patients, could be a university hospital, or even a community hospital, and therefore gives us a wide range of organisms from a wide range or diverse patient population. The clinical centers across the United States were invited to submit isolates from specific eye infections. That is, Staph aureus, coagulase-negative staph, strep pneumoniae, Haemophilus, and Pseudomonas. These organisms were picked since they are the common ones that cause serious eye infections. So, to understand surveillance data, we have to understand what is collected. And this is important because we often get data thrown at us. It could be in a throwaway journal or in a peer-reviewed journal, and we need to understand some of these terms to interpret the information correctly. One of those is MIC. MIC stands for Minimum Inhibitory Concentration. And what that does is it determines the lowest concentration of a specific antibiotic that will inhibit growth of a specific microorganism. And it's done overnight in a 24-hour period. And you end up with your final endpoint is micrograms of the antibiotic per ml. And there are different ways of testing. One is a simple way, an agar dilution test called an E-test, and one is a broth dilution test. And I'll show you examples of both. This is a agar plate, which we're used to seeing, a blood agar, and it has that stick in it. What that E-stick is, it has antibiotic in it, but the concentration changes as you go down the stick. So the highest concentration is towards the top, and the lowest concentration is towards the bottom. And in this agar plate, you can see sort of a whitish yellow where organisms are growing, and then you can see a blood agar part where it's nice and clean. And what you do is read where those two cross each other to tell you what the MIC is, or the minimum inhibitory concentration, which will be reported, and you can't read in this slide, but it'll tell you the micrograms per ml. This is a pretty good, simple way of determining the MIC. but a more sophisticated way is shown in the next slide. And this is what was used in ARMOR and in the Ocular TRUST study. This is a Broth Microdilution method. Here we take, we do a tissue culture plate here, 96-well plate. We put the same number of microorganisms in every little circle there, but what we change is the concentration of the antibiotic. And listed on the top of the graph there, 512 down to control, is the concentration or micrograms per ml of the specific antibiotic tested. And what you can see in the control, that column all the way to your right, it's kind of hazy or obscured, meaning the organisms were able to grow nicely. When you look all the way to your left, you can see it's sort of black. The organisms could not grow. And by looking across this plate, you can determine what the MIC is. And it's a nice way because you're testing a lot of concentrations very carefully. And this is really nice data that's very specific and repeatable. Typically, we do it twice with each isolate, with each antibiotic that's tested, and it gives you really good data on MIC. When we talk about MICs, we're talking about microorganisms and a drug being tested in growth media, whether it's an agar plate like I just showed you, or whether it's in a test tube or culture dish with just media. So this is the interaction. This is a laboratory test. It gives us great data. But remember, when we're dealing with people, it's not quite the same as agar or broth in the laboratory. So it's a great source of information, but it doesn't necessarily tell us everything, how that antibiotic is going to work in people. So one of the other things we do is looking at how drugs work in people. Now, the typical way of doing that is looking at cutoffs, resistant, intermediate, or sensitive, based on clinical efficacy of systemic drugs used for systemic infections. And the guidelines used here follow the National Committee for Clinical Laboratory Standards that sets USA standards for sensitivity testing. And that's what we often get from the laboratory. You'll see an S for sensitive, I for intermediate, or R for resistant, next to the isolate that was collected from your patient against a series of antibiotics that were tested. This is great information because it tells us about using that specific antibiotic for actual people with actual infections. The drawback, however, is that the breakpoints here that are listed, the resistance, intermediate, sensitive, are dependent on systemic treatment, such as for pneumonia. It is not dependent on eye treatment. We have the advantage, of course, in eye treatment that we deliver the drug right to the infection typically, such as a corneal ulcer or conjunctivitis. That's not the same, of course, for an abscess in the liver or some other more serious systemic infection. The other issue is there may be no breakpoints available for a drug that is not used systemically. And then we're going to have to fall back on the MIC numbers to understand where that drug may be effective for treating eye infections. So what we're finding out is that in vivo testing, we're looking at the microorganism, again the drug, the antibiotic, and now we're looking at the patient. When you have a more complex population here, the microorganism and the patient, the results are not going to be the same as what we get in the laboratory. So keep in mind that our laboratory results of MICs may or may not reflect what we can do with people, particularly in ophthalmology when we give the drug topically. However, this is, again, another good source of information, that resistance, intermediate, or sensitivity information that we get based on systemic treatment for systemic antibiotic use. ARMOR methods looked at minimal inhibitory concentrations at MIC for various antibiotic classes and was determined by an independent central laboratory using that dilution technique which I showed you in a previous slide. And it determined the MIC, the lowest concentration that inhibited growth. And what that means is if it's a low number, you have high potency. We use that broth dilution technique that I showed you, and based on the resistance, intermediate, sensitivity determination, based on Clinical Laboratory Standards Institute, known as the CLSI guidelines. ARMOR methods included looking at isolates and defining them as susceptible, intermediate, or resistant, dependent on those systemic breakpoints. Remember, a breakpoint will tell you the threshold MIC value based on how PK/PD, meaning how it worked systemically, and say it's susceptible or it'll say it's resistant. And staph organisms were defined as being resistant or sensitive, dependent on oxacillin susceptibility, which is basically the way that is determined for all isolates, whether it's for pneumonia or an eye infection. Let's take a look at the ARMOR results over the last 5 years. An impressive number of isolates were collected, over 3,000. There were 72 sites that contributed to this study. Again, it gives you a broad view of what's going on in the United States. There were over 1,000 Staph aureus isolates. Nearly 500 were methicillin-resistant Staph aureus. Over 600 were methicillin-susceptible. There were nearly 1,000 coagulase-negative staph isolates collected. Again, about half methicillin-resistant and half methicillin-susceptible. There were over 300 strep pneumoniae, nearly over 350 H. flu, and nearly 400 Pseudomonas isolates. The numbers are clearly impressive and not likely be able to be done by a individual center, even a very busy one. When you look at this slide, looking at resistance in Staph aureus, first we know that staph is an extremely common organism, not just for keratitis, even conjunctivitis, but also for endophthalmitis as well. So it's important to us to understand what goes on with resistance and sensitivity with staph. So when you look on the left part of your graph, you see we're looking at Staph aureus. And when you look at the series of antibiotics listed along the y-axis, starting with azithromycin and at the bottom vancomycin, you can see that there is resistance to Staph aureus. And it seems to be most common in this large number of isolates tested to azithromycin. And fortunately, at the bottom, you can see vancomycin is excellent, in that all of the staph tested were sensitive to vancomycin. When you look at coagulase-negative staph, something that's often considered a normal inhabitant, however, we well know from our ophthalmology experience that it can be a pathogen causing keratitis and causing endophthalmitis, we see a similar pattern that azithromycin is not a great antibiotic for this one, yet at the bottom of the page there, vancomycin works pretty well. And you get a feeling as you go down what works best or not when we looked at the isolates we tested. Take a look at the MIC testing for staph infections. Now this is important to take a look at because we mentioned not every antibiotic can we define breakpoints. Because if the antibiotic was not used systemically, breakpoints such as sensitivity or resistance are not available. So specifically, becifloxacin, one of our newer fluoroquinolines available topically for ophthalmic use, is not used systemically. So you have to look at MICs then to get a better idea of how useful it would be for different infections. So if you look at Staphylococci, first looking at the Staph aureus on the left in your graph there's almost over 1,000 isolates were tested. And the MIC for vancomycin is extremely low, meaning more potent, at 1. But what's equally interesting is when you look at becifloxacin, it's 1 as well. And also for moxifloxacin and Gatti and Cipro, you can see that the MIC is increasing, suggesting at least in the laboratory testing, these are less potent antibiotics. With azithromycin not really off the map in terms of not being sensitive. When you look on the going down to further columns to the MRSA, or methicillin-resistant organism, again you see that vancomycin is great at 1. Becifloxacin is still excellent at 2, but the other fluoroquinolones tend to start creeping up, suggesting again that the vanco and beci are more potent, again in the laboratory testing. On the methicillin-sensitive organisms, all of them seem to do pretty well up until azithromycin. When you look to the right, where you're looking at CONS, or coagulase-negative staph, again you see when you look at all of the organisms, the vancomycin and becifloxacin do well. The other fluoroquinolones do pretty well, not Cipro, I would say tobramycin doesn't do too badly. Azithromycin is not so good. Again, when you look at the methicillin-resistant in the coagulase-negative staph, the middle column there to your right, you can see that Vanco and Besifloxin do pretty well. The others tend to go up a little bit. Interesting enough, tobramycin is pretty good, but azithromycin, again, is not very good. And when you look at the methicillin-sensitive, the very last column to your right, again, you see pretty good numbers for everything except azithromycin. This graph looks at multi-drug resistance. When we talk about multi-drug resistance, what we're talking about is a particular isolate resistant to not just one antibiotic class, but to several. And what you look here is taking our methicillin-resistant Staph aureus, you can see that nearly 90% of them were resistant to 3 classes. That means it may be kind of hard to find an antibiotic that's going to work well. When you look at the bottom part of this graph at multi-drug resistance, and here you're looking at methicillin-resistant coagulase-negative staph isolates, you see that over 70%, almost 80%, are also multi-drug resistant to several classes. So one of the problems is you can't just switch and say, oh, well, this one didn't work, we'll take the other one, because these organisms tend to be multi-drug resistant, meaning a lot of different antibiotics will not work effectively, particularly when testing in the laboratory. Resistance in strep pneumoniae and Pseudomonas in the many isolates that we looked at is shown in this graphic. When you look at strep pneumoniae, what you find again is that the erythromycin had some resistance problems. Penicillin as well. Penicillin is done as a marker. Of course, we do not use penicillin as a topical agent for ophthalmic use. As you go down here, you can see most of it worked pretty well. Therefore, you have a wider variety of drugs to use. The red a little bit in the strep pneumoniae is for chloramphenicol. The other drugs, antibiotics seem to work quite well. Pseudomonas, we know, a very serious source of infection for eye disease in the cornea and certainly in endophthalmitis. What's interesting is that, again, azithromycin had some problems with intermediate and resistance, a little bit with chloramphenicol, which is really not too popular in the United States, but is often used in elsewhere in other parts of the world. But in general, we've seen pretty good sensitivity, even with some of the fluoroquinolones, such as Moxie, though it's not 100% even with Moxie. So, what does the ARMOR study tell us? It tells us that methicillin resistance, which is definitely prevalent in staph organisms, staph isolates, and those isolates show a lot of multi-drug resistance, meaning one antibiotic may not work, but it may indicate that some of the others won't work as well. It shows us that surveillance is probably warranted. We're not going to know this information from any one site or small collection of isolates that are reported. And current resistance should really be considered when you're making that judgment on what antibiotic to pick. Your decision is important, and it should be based on evidence that's available to make the best choice. Well, what have we talked about today? Now we know what MIC is, minimum inhibitory concentration, which is tested in the laboratory with agar or broth media to determine the lowest concentration of an antibiotic that will prevent growth of a particular organism. The breakpoints, such as resistance, intermediate, or sensitive, those are related to systemic infections and are really helpful at looking how the drug works systemically in people. And we looked at the concept of in vitro testing in the laboratory versus in vivo testing in clinical experience, and understand that information that's currently available doesn't always reflect what we find in treating eye infections. So what's the take-home message? MIC, a laboratory testing. Breakpoints, a systemic treatment. Keep both those pieces of information in mind when you're dealing with a serious eye infection to help you both understand the information your laboratory is giving you and to understand what you can use it for in selecting an antibiotic for eye use. But remember the 3 Bs. We want broad spectrum, and the surveillance studies are very helpful in understanding what works in general and taking that home to treat our specific patient. But we also want to know something about bioavailability. Can the drug we're picking get into the target tissue, whether it's the cornea or inside the eye in endophthalmitis? And we also want to know something about biocompatibility. BAK is still the most commonly used preservative, and we know from data we've done in the laboratory and others as well that any BAK concentration can interfere with healing. So if possible, we want to pick the lowest concentration or the lowest number of delivery of that drug per day. So if you're giving a BAK drug 5, 6, or more times a day, you are giving a lot of BAK, which itself can interfere with healing as well. So in summary, antibiotic resistance today is an important topic for you and me as clinicians. Surveillance studies give us a starting point when we select a drug for a specific patient, so look at the data from Ocular TRUST in ARMOR. And remember, no antibiotic works all the time. Methicillin-resistant or MRSA is more common than ever. Don't forget it can affect your patients. It's not just out there in the publications. Methicillin resistance for coagulase-negative staph is also on the rise, and we should look forward to further reports and studies on surveillance to help us best select an antibiotic and give the best treatment possible for our patients, both in treating infections, and I know it's off-label for prophylaxis as well, which is common in the United States eye treatment as well today. So hopefully you have found some of this information useful and helpful for you to select the best organism, the best treatment for any specific organism that you may encounter in your patient population. Thanks for joining me today, Penny.
Thank you, Dr. Asbell, for that great presentation. I'd like to ask you some commonly asked questions regarding the antibiotic resistance and the ARMOR study in general. My first question is, can clinicians use MIC to determine which antibiotic to choose?
Let's take a look back at one of the slides I presented a little bit earlier, which shows the MICs for staph. When you look at these MIC numbers, you can see that they vary depending on which antibiotic we tested. Very low all across the top for vancomycin, and very high at the bottom for azithromycin. So the MIC is a good test of potency. And basically we want the lowest number possible when we're picking an antibiotic in terms of picking one that is most potent. So look at those MIC numbers and use those to help you direct the most potent antibiotic that you might use for that particular isolate.
My next question is, which is better, MIC or the resistance sensitivity report?
Well, the answer is both. They give us different information. Remember, the MIC is done in a laboratory looking at the organism, the agar, and the antibiotic working together. When you're looking at the sensitivity report where it gives resistant or sensitive or intermediate, you're looking at those cutoff points developed from systemic treatment of serious systemic infections. So both of them are helpful. One tells you about the laboratory. One tells you how that antibiotic and that infection would react in a person. So neither one of them are really telling you specifically about eye infections, but you use the two together to figure out how to best pick them. So don't ignore either piece of information, but know that they're different and they give you different information. We mentioned also that some antibiotics that are available for eye use do not have breakpoints, because unless they're used systemically, breakpoints have not been developed, and then we have to rely more on the MIC number from the laboratory testing.
My last question, Dr. Asbell, is what drug should clinicians choose if concerned about MRSA?
Well, probably the number one drug, if you're really sure that, or have a very good indication it's MRSA, is probably vancomycin. Unfortunately, as you probably know, in the United States, vancomycin is a compounded antibiotic, meaning a compounding pharmacy needs to make it up for you. It's not immediately available. So if you're going to pick something that's commercial, the testing suggests from the laboratory that probably trimethoprim is helpful, chloramphenicol, and even becifloxacin may work. So you want to start something right away, but you do want to take a culture, especially if it's a serious infection, to see what the results are going to be. And depending on the clinical course and the laboratory results, you may need to change your antibiotic you use as you go forward in following that particular patient. What we really need is something commercially available that we know is going to work well against MRSA. That's not around now. So do think about the data you get from the laboratory. Do think about what that patient and their risk factors. Are they from a nursing home? Have they just had a pneumonia, which has been proven to be MRSA? Those issues can help you decide more appropriately what antibiotic to begin with, and then as you follow them clinically, where you should go in terms of changing if need be.
Thank you, Dr. Asbell. This concludes today's webinar. I wish to thank Dr. Asbell for a great presentation on antibiotic resistance among ocular pathogens, the ARMOR study, 5-year surveillance results. I also wish to thank you, the listeners, for joining us today. On behalf of Dr. Asbell and Ophthalmology Times, we appreciate your time and attention. Have a good day.